Thank you, Dr. Adila, for your very nice introduction. So, everybody was hungry, so I will take a long time for me to deliver this speech or this talk. So, I'm talking about the post-operative pain management with non-opioid. Define pain as an unpleasant sensory or emotional experience associated with actual or potential tissue damage, or described in such terms, meaning that patient may perceive the pain or patient may experience a pain even though the tissue is, the damage is already healing. So that's how we explain the pain. For example, is a post-amputated patient, BKA or AKA, even though the healing process is completed, but patient still experience a pain. So, by knowing we're supposed to know the pain physiology and the pain pathway to select the kind of or the suitable type of drug to reduce or to relieve the pain. So, pain pathway actually following the tissue damage. So, this tissue damage will produce a substance mediator, will activate the nociceptors, and pain impulse will be carried by A delta and C fibers to the dorsal horn. Then they go to the spinothalamic tract, to the thalamus, and to the high center through the, for example, of the mediators are prostaglandin, bradykinin, substance P, serotonin, histamine, and it will cause peripheral or central hyperalgesia. So this is the pain pathway diagram shown to make it more simple and clear. So free nerve endings occur in a soft tissue, bone, nerve, anywhere carried by the afferent A delta and C fiber. So the transduction process occurs in a free nerve ending, followed by the conduction carried by the A delta and C fiber to the dorsal horn, and transmission occur here up to the central cortex. And how patient brain the brain will perceive what kind of pain that we have, and then we express it as a pain, either it's a cold, hot, and we try to remove the stimulus of the pain. Okay, so pain can be classified by the duration of the pain occur, which is it could be acute or chronic. Acute pain usually less than 3 months, but the pain, if the pain persists more than that, so we categorize it under chronic pain. Besides that, we also can classify pain based on the pathophysiology. Either is due to nociceptive component or due to neuropathic component. So nociceptive component can be due to pain from the bone, soft tissue, from the skin and all that. But the neuropathic is clear-cut from the nerve injury. So, what's the big difference of acute pain and chronic pain? Definitely, they are different. They are different because both the biological markers such as hypertension, tachycardia won't be occur in a chronic pain. But most of the time, patients have tachycardia or tachypneic because of pain. Whereas in chronic pain, the comorbidity symptom will be occurred such as depressive, anxiety disorders, and so on. So, as everybody knows, in the KKM, we have implemented the pain as a fifth vital sign, meaning that as everybody know that the other 5 vital signs that we monitored in a ward, we have to add pain as the 5th vital signs. Okay, why? Because it is important for us to monitor the pain in post-operative patient. So, important of post-operative pain management because vital signs are taken seriously. If pain were assessed with the same zeal as other vital signs, it would have a much better chance of being treated properly. So, throughout the years from 1995 and 2003, they have the study. Several studies stated that 82% of patients have pain and 13% patients have slight pain, 47%, more than 50% have moderate pain, 21% have severe pain, and extreme pain about 18%, which is very significant. So meaning that pain is suboptimal. So why we do need to manage or to reduce the pain post-operatively, because acute post-operative pain due to inadequate pain management will lead to the clinical and physiological changes, such as patient is hypertensive, it is not good for the cardiac compromised patient. Patient can't breathe because abdominal pain, so they can't breathe in properly, end up with atelectasis and all that. So all of this, patient not moving, decreased mobilization because of the pain, will increase risk of deep DVT, pulmonary embolism, myocardial infarct, and coronary ischemia. For all of that, patient may end up with longer hospital stay due to PE, or longer hospital stay due to, possible is what we call it is respiratory problem, pneumonia, acquired pneumonia and all that, and it will reduce the patient satisfaction, increase the patient complaint, and increase the health costs. Bear in mind, inadequate acute post-operative pain, inadequate pain management during acute phase will lead to the induction of the chronic pain. When patient end up with chronic pain, so the morbidity, mortality will be more higher, decreased quality of life, long MC and all that, decreased patient satisfaction, and consequently will increase the health costs. So that's why proper, adequate acute pain management is very important to prevent the chronic pain. So different surgical procedures have different characteristics of pain, meaning that laparotomy, for example, because of visceral pain, or they do the TKR, or they do the THR. Most of the time TKR, THR is because of the musculoskeletal pain. So different type of pain have different type of medication that's suitable for the patient, and different pain intensity. For example, thoracotomy is more painful compared than appendectomy. Okay, different location of pain. Okay, dental tooth extraction is less painful compared than TKR and so on. Besides that, the different risks and benefit of analgesic technique also important, because if patient have medical problem, for example, patient is coagulopathy, you can't do regional analgesia, but regional may be good for the patient. So it is, you have to consider all these things. So what is the best practice for management of acute post-operative pain? So I will here we suggest 5 factors that provide the best practice for post-operative pain. First is the optimal post-operative management begin in the pre-operative period, meaning that you must conduct pre-operative patient evaluation in a clinic, or in a NS clinic, or in a ward. Ask about the patient pain history, ongoing or chronic pain issue, or maybe patient is opioid tolerant, patient is already on methadone, or patient is already on morphine and all that. Okay, comorbidities, patient have underlying cardiac or renal or the liver impairment and all that, and concurrent medical and cognition and coping strategies. Next is document in patient medical records and discuss pain management strategy and expectation of post-operative pain to the patient. Patient can choose whatever they like. Second is measure pain regularly using a validated pain assessment tools. That's why I'm stressed here that pain as a fifth vital sign is very, very important. So regular and routine assessment of pain will result in improved pain management. I believe everybody know where and when you're supposed to measure the pain score. Patient own assessment is the most reliable. Measure pain score both at rest and movement, reassess pain regularly, and document pain assessment as part of the routine observation. Okay, what is other routine observation? Take a blood pressure, temperature, pulse, and so on. Okay, so this is a very common, I think everybody know about that. Pain assessment tool is a standard suggested by recommendation from the KKM hospital. Next is to ensure all post-operative patients receive safe and effective analgesia. So, some of the patients, they may have sensitive towards the opioid. So, the multimodal analgesia is the very good of choice. So, when using analgesic on regular basis, have additional PRN medication available for breakthrough pain, and use individualized dose and appropriate dose interval and titrate to the patient response. So we must make sure whatever you give, you monitor. You give opioid, you must monitor the sedation score. You give opioid, you must monitor the respiration score, because opioid add to the central nervous system. So what is the multimodal analgesia? Multimodal analgesia is the use of more than one method or modality of controlling pain. For example, drugs from 2 or more classes, opioid and non-opioid, plus non-drug treatment to obtain additive beneficial effect, reduce side effect, or both. Okay? So this is an example of the multimodal analgesia. As far as you know the pain pathway, so you know what kind of modalities, what kind of analgesia, and what kind of the intervention that you want to give to your patient to make sure patient is pain-free without significant side effect. Okay. Next is the monitor and manage adverse effect. As I mentioned just now, monitors patient prescribed opioid for respiratory depression and sedation, monitor nausea and vomiting, and monitor for other adverse events, urinary retention, and so on. So monitoring is very important. Last, you have to communicate ongoing pain management plan to both patients and your primary team or primary healthcare professionals. For example, in the operation theatre, I suppose everybody of us practice the SSSL, right? So SSSL, you must communicate with the surgeon. You just tell them, this patient, I will give epidural analgesia. Okay, I will give bupivacaine with fentanyl infusion. So please don't give any opioid, systemic opioid in a ward. So the primary team will know. They won't give subcut morphine or subcut betadine or IM morphine, so on and so on. You know, which is always happen in ward because lack of communication. Okay, review analgesia requirement and consider relevant risk factor 24 hours before discharge. You can't discharge your patient just after you off the morphine infusion. Because especially for patients we have kidney impairment, because the metabolism will be prolonged. If this prescribing a strong opioid, consider limiting quantity prescribed. Okay, prescribe drug for symptomatic relief of side effect where necessary. So we zoom to the analgesic and we zoom to the non-opioids, which are acetaminophen, paracetamol, non-steroidal anti-inflammatory drug, which is NSAIDs, and COX-2 inhibitors. So non-opioids, as I mentioned just now, is no physical dependence effect, no tolerance, meaning that no matter what patient take, you will not cause tolerance, but they have ceiling effect. Ceiling effect means you can't give the more than maximum dose. If you give more than maximum dose, the side effect will occur, but the analgesic effect will not be occur. Okay, so ceiling effect is a synonym with the non-opioid or NSAID. So we go to the paracetamol. Everybody know paracetamol, okay? When the patient come to see you, oh saya beratur lama-lama 2 jam, 3 jam kat klinik, doktor bagi Panadol saja. But bear in mind, paracetamol is anti-analgesic effect. It's not antipyretic, okay? So actually what paracetamol works is, it is selective inhibit COX-3. Currently we have COX-3, cyclooxygenase 3. Okay, maybe after 5 years back, 5 years later, we have COX-4 and so on. Okay, so they are weak inhibitor of COX-1 and COX-2, and analgesic and antipyretic, but no anti-inflammatory activity. Less side effect, less gastric irritation or the complication because of the no anti-inflammatory activity. So, the action of paracetamol is analgesic, antipyretic, and a little bit of the anti-inflammatory, so that it is relatively safe. But have to be careful if the patient has liver problem. So we go to the other non-opioid, which is NSAIDs. Okay, how the NSAIDs works? NSAID is a group of drugs which is a mechanism of action is inhibit both peripheral and central cyclooxygenase or COX by the so that you reduce the prostaglandin formation. Why we experience the pain? Because we have a lot of prostaglandin. Okay, so there are two isoform of COX, which are COX-1 and COX-2. COX-1 basically is a constitutive of physiological, which is occur in our body, physiological, meaning that it's normal. Whereas COX-2 is inducible and inflammatory, meaning that when you give patient NSAID, the NSAID or traditional NSAID will both block the COX-1 and COX-2. Bear in mind that COX-1, the effect of the COX-1 is to maintain the normal constituent of the body. COX-1 will have a gastric cytoprotection, as the COX-1 protect our gastric, our gut. COX-1 will cause renal sodium water balance the sodium renal water, and COX-1 also maintain the platelet aggregation. So by giving NSAID, you block the COX-1, meaning that you will cause the problem with the gastric protection, renal protection, and platelet aggregation function. COX-2 will only be induced, meaning that if we have nothing, we have no injury, no infection and all that, our body will not produce COX-2. So once we have injury or we have infection, COX-2 will be induced, and COX-2 selective analgesic will only bind the COX-2 and preserve the COX-1. You see, COXIBs or COX-2 inhibitor will only block the COX-2 to preserve the COX-1. So meaning that by giving the NSAIDs, patient will have therapeutic effect, but on the same time, patient have the side effect. On the other way, on the other side, by giving the COX-2 inhibitor, they only bind or block the COX-2, but they preserve the COX-1. So patient have therapeutic effect without side effect. Okay, this is about COX-1 and COX-2. This is our normal NSAID. In a counter, you can buy this medication in a pharmacy. So NSAID bind COX-1 and COX-2, analgesic effect, but a lot of side effect. Okay, so what is the adverse side effect of NSAID? The three major side effects are GIT bleeding, because no more gastric protection. Renal failure, okay, because not balance on sodium water balance and all that is affected. And congestive heart failure with increasing age is an important factor. So they done a study, the primary care group of 100,000 with 3,500 over 65 patients taking NSAID. They will be in 18 hospital admission every year for the upper GIT bleed, 10 for acute renal failure, and 22 have congestive heart failure. See, we simply give Voltaren, Mobix to the elderly patient. You have to be careful. The majority of the renal and heart failure cases would be aged more than 75. Okay, the others, beside the GIT problem, NSAID also cause the hepatotoxicity. Will cause the alter in liver function. Patient presented with jaundice. Okay. And hematological, it inhibit the platelet cyclooxygenase to increase the bleeding time, bone marrow suppression. So you have to be careful. Post-op patient, bleeding 3-4 liter, HB7, platelet 70, yet you give NSAID. So the bleeding will be furthermore worsening, isn't it? So you have to check your hematological status. CNS, the NSAID will cause headache, hallucination, seizure, tinnitus, aseptic, meningitis, and be careful with the NSAID, it will cause hypersensitivity reaction, especially for the asthma patient. Okay, so the limitation of the traditional NSAIDs are GIT, ulcer. Okay, we go to the COX-2 selective inhibitors, which are Parecoxib or Celebrex, Parecoxib or Arcoxia, and Parecoxib, which is Dynastat. Parecoxib is the only IV preparation for the COX-2 selective inhibitors. So we go to the relationship of the COX-2 and sensitization to the pain. As I mentioned just now, cyclooxygenase will act at the peripheral and central. So peripheral sensitization will occur due to the express of the tissue injury, express following tissue injury. prostaglandin release and all that, will increase the nociceptors and sensitivity to pain. And the peripheral sensitization will lead to the COX-2 induced in a central system as well. So all the peripheral sensitization, central sensitization will lead to the hyperalgesia and allodynia. So with the normal stimulus, patient will experience the pain. So we call it allodynia. And with the stimulus intensity, it doesn't cause severe pain, but patient got very severe pain. We call it hyperalgesia. So this is pain sensitization because of the peripheral and central sensitization occur following the tissue injury. So this is a dosing of the COX-2 selective analgesia. We have Celebrac, 200 preparation and 400 preparation. And Parecoxib, Arcosia, we have 90 and 120. Basically 90 for the chronic pain and 120 for the acute pain. And we have Parecoxib of Dynastat, which is 40 mg per ampule. So what is a Dynastat? It is the newest NSAID COX-2 inhibitor available in parenteral form, IV, preparation 40 mg. Dose is BD for 2 days. Side effects similar but less to the other NSAIDs. So as the efficacy of the Parecoxib, actually Parecoxib is the prodrug for the valdecoxib. The active one is the valdecoxib. So they compare the Parecoxib with morphine used in gynecological laparatomy procedure. They give the patient 6 mg IM morphine, 12 mg and 40 mg of Parecoxib or Dynastat, and the other limb is placebo. So 4 group. So the result showed that patient with morphine 12 mg and Parecoxib 40 mg have a higher incidence of the excellent and good pain relief compared than the placebo and morphine 6 mg. And pain relief, they also done a study with the pain relief with the Parecoxib for the post TKR, total hip arthroplasty, comparison with the placebo. So study results showed that patient with group with the Parecoxib 40 mg have a complete pain relief, much better than placebo and Parecoxib 20 mg. What is safety of Parecoxib in the management of post-operative pain? Upper GIT safety of Dynastat is there compared to the ketorolac. Ketorolac is the normal traditional NSAID. Compared with Parecoxib, Parecoxib is safer compared than NSAID. This is the cardiovascular safety of Parecoxib or valdecoxib in the post-operative setting. Just now is a cardiovascular GIT, now is a CVS. So look at the any cerebrovascular event, more or less the same. Any vascular thrombosis event, more or less the same. So there is no different. Dynastat or Parecoxib also have an opioid sparing effect, meaning that when you give Parecoxib, you will reduce the opioid consumption. So when we reduce the opioid consumption, the side effect will be less. Requirement of opioid will be less, patient more alert, no nausea, vomiting, patient will be more, can mobilize, can go back home early. So the healing process will be faster. Same thing with the reduced opioid consumption and opioid-related adverse effect. As I mentioned just now, reduce all the opioid side effect. So Parecoxib, the advantage of the other analgesics are they preserve the platelet function, they improve the GI tolerability because they maintain the COX-1 activity or physiological function. They will effect on bone healing. They release effect on bone healing in spinal fusion similar to placebo, meaning that no different of placebo and COX-2. And COX-2 inhibitor tolerated well in patient with aspirin sensitivity. Okay. So next is how to prepare the Dynastat, especially in a ward. So reconstitution of the Dynastat, Dynastat must be not mixed with any other medical product. Okay, in those patients where the same IV line is to be used to inject another medical product, the line must be adequately flushing. Okay, after Dynastat injection with a solution of non-compatibility. After reconstitution with the acceptable solvent, Dynastat may only be injected IV or IM or into IV lines delivery the following: sodium chloride, glucose, sodium chloride 4.5%, 0.45%, and glucose 5%, or ringerlectin. Injection into an IV line delivering glucose of 5% in ringerlectin solution for injection or other IV fluid not listed above is not recommended, as this may cause precipitation from the solution. So this reconstituting of the Dynastat will be available in the template, the box of the Dynastat. Please have a read before you prepare the medication. So this is how you have to remove and prepare the medication. So, as a summary, the advantage of Parecoxib 40 mg IV or IM include opioid sparing effect, decreased opioid-related adverse events such as opioid-related symptom severity and other distress, nausea, vomiting, no adverse effect on bleeding time, improved upper GI safety, no significant deleterious effect on healing after spinal fusion surgery, safety in asthmatic patient with aspirin exacerbated respiratory disease or bronchospasm, and no significant drug interaction with propofol and midazolam. So, treatment plan for pain management should be address comorbid condition, gender and culture differences, improve the activity and function, be cautious with polypharmacy, okay, consider interventional approach, and complementary and alternative treatment which should be considered. So, better quality of life. Before I end the session, so achieve pain control, the earlier the better, okay? Because once the patient entered the chronic pain phase, it's very difficult for them to be cured. And they will end up with the polypharmacy, they will end up with the functional problem and all that, and they will end up with the disability. For that, I thank you.